Chris Ham, thank you for taking time to talk with me this morning about integrated services and commissioning.
Our pleasure.
Can we start with looking into the future a wee bit when we have clinical commissioning groups on the ground? How do you think those clinical commissioning groups can be encouraged to be innovative and to commission integrated care?
I don't think clinical commissioning groups need a lot of encouragement. From the contact I've had with some of the GP leaders, they're champing at the bit. They believe they can be more effective as commissioners than PCTs have before them. What I think is important is they need a permissive framework which says we'd like you to be innovative around integrated care in particular, and they don't feel that the government's put barriers in the way of them doing that. So I think we're all ready to go.
So the other part of the arrangement is at the more national level. You've got the NHS Commissioning Board and particularly Monitor. Do you see them having a particular role?
It's really important we get those national arrangements right. It's going to be quite complex because we have a number of players on the pitch. Monitor as a regulator, the commissioning board providing overall guidance, and if we get it wrong there could be conflict, mixed messages between those organisations. If they can align what they're doing to support clinical commissioning groups, there ought to be a basis for taking forward these more integrated models of care where they will bring benefits and to create more choice and competition in other areas of care where that's appropriate. Both are needed.
And do you have any specific advice for the Commissioning Board and Monitor?
Well, Commissioning Board, first and foremost, ought to provide resources and expertise to support clinical commissioning groups, because it won't make sense for every group to have to reinvent the wheel every time around how to commission integrated care. For Monitor, what's very important is that as the economic regulator for healthcare, recognise that healthcare is very complex. It's different from other sectors, that we need to get a nuanced approach to regulation where there's an emphasis on both competition and integration.
And your recent report released today called Commissioning Integrated Care in a Liberated NHS suggests that work is required around pricing for NHS services and that more could be done to encourage integrated care in that area. So anything specific in mind there?
Well, what we argue in our report is that if we want to support integrated care, there need to be the right incentives, the right payment systems in place to reward those who deliver integrated care for the quality and the outcomes of what they do. And payment by results is not designed for that purpose. It was very much introduced to support more activity around planned and elective care. It served its purpose reasonably well in that regard. Now we need to experiment with other forms of pricing and payment, much more based on funding a particular disease or funding healthcare for a population of people, but providing rewards too where good quality care is delivered.
So what might be a starting point?
A good starting point in our view would be to build on examples that we've seen in Smethwick in the West Midlands, where a group of practices have worked in this way. They're serving a local population, they're trying to improve care for people with long-term conditions. They've been given a capitated budget to provide that care, and that seems to us to be a really good example that we now need to build on in future.
Looking at the wider policy reform, there have been moves in both competition policy and also increasing choice. On the face of it, it appears that there might be some tensions between those and also enhancing integrated care. You got any comments on that?
We don't believe there is an inherent tension between wanting to see more choice and competition on the one hand and greater collaboration or integrated care on the other hand. It goes back to the point about healthcare is different, it's complex. You need to have a quite sophisticated approach to how you regulate what happens in healthcare. So in some areas, if you're deciding which hospital to go to for your outpatient appointment or your test or your operation, there should be open choice and real competition between hospitals. If though we're talking about the needs of frail older people with complex needs, long-term conditions at risk of unplanned admission to the hospital, that's where we would argue it's much more important to integrate for providers to collaborate around the needs of patients, and choice will be less relevant there.
We've got new clinical commissioning groups about to start, possibly with ambitious plans for developing integrated services. What would your advice be to them?
Well, clinical commissioning groups will need support and help. They have lots of ideas, they really want to be innovative, but they're taking on a huge responsibility in quite a short period of time. So what I hope we'll see is the clinical commissioning groups hanging on to that spirit of innovation, but looking to the commissioning board for support, looking to monitor for support, to give them the tools to do the job. That's about advice on how you go about commissioning, including integrated care. It's about innovation around pricing and payment systems, so we put the right mechanisms in place. It's about advice on what procurement route you need to take if you're going to pursue integrated care. So centralisation around some things, devolution around other things, getting that balance right is going to be really critical.